Hi and welcome to Physiotutors podcast episode 60. In this episode, I will talk to Canadian researcher Yannick Tousignant-Laflamme. Yannick is a professor at the School of Rehabilitation at the University of Sherbrooke, and his research activities target the management of chronic pain associated with musculoskeletal disorders and particularly low back pain. Hi Yannick, welcome to the podcast.
Hi, thanks for the invitation. It's a pleasure for me to be here with you and interact on a very interesting topic.
Yeah, great to have you as a guest. And Yannick, today we want to talk about a model that you developed in particular called the Pain and Disability Drivers Management Model. And we first came across it in your work in your conceptual paper called Rehabilitation Management of Low Back Pain. It's time to pull it all together in 2017, where you first presented the model. Can you briefly describe what it is?
All right. So the model we've proposed is a structure. We would like to call it also maybe a diagnostic framework. And why do I like to call it a diagnostic framework? It's because for many persons suffering from spinal pain, especially low back pain, the diagnostic that they receive is very it's not very informative. They have low back pain, non-specific low back pain, lumbar sprain. What is it exactly? Yes, it's pain in the low back, but people that consult us, healthcare professionals, they want to know what's going on, what's driving this, and what to do with it. They want, of course, to have less pain, but most importantly, they want a better understanding of their condition. Now, the model has been proposed and developed to try to make something really complex, low back pain, 3 words, which may sound simple. In fact, it's a bit more complex than only pain in the low back. It's a very heterogeneous population, so there's many subgroups within that population, and it's complex for the clinicians to try to identify, all right, what's the main driver, what are the main factors driving my patient's pain and disability. So the model that we developed was there to try to facilitate this, to provide a structure for clinicians to help them identify the drivers of pain that goes beyond the usual biomechanical drivers of pain. As physical therapists, I think we are really good at that, but we do have to recognize that there's more than bio in the biopsychosocial model of pain. And the model was proposed also as a mean to try to integrate a true biopsychosocial approach with these patients.
Okay, great. I'm looking at your model. I have it on the paper printed out right next to me. And you guys try to portray the 3 dimensions based on the different ICF domains. So you have drivers of pain and disability, and drivers of disability. And you also have 5 domains within those 3 dimensions, which you call nociceptive drivers, nervous system dysfunction drivers, comorbidity drivers, cognitive emotional drivers, and contextual drivers. My question is, why those 5?
So why those 5? That is a good question. So we searched the literature and we try to identify what are the drivers of pain and disability. We found out that there were mostly studies helping us to find, well, mechanistically, what's driving pain, what's driving nociception, what's driving nervous system dysfunction. So there's specific mechanisms that are driving the patient's pain. But those mechanisms are not only in regards to nociception or nervous system dysfunctions, they also include prognostic factors. So factors that are going to help us identify who's going to improve or not. Usually there are negative prognostic factors. And those prognostic factors were mostly aligned with the psychosocial aspect. Hence, we developed the 5 domains accordingly. So 2 domains mainly target pain-related mechanism. So for nociceptive pain and nervous system dysfunctions. So those are domain 1 and 2.
Yeah.
Domain 4 and 5 are domains that are really related to the psychosocial components, which are mostly drivers of pain and disability, or mostly disability. So all the cognitive affective factors, maladaptive behaviors, and of course our social environment. There's 24 hours in a day. We spend about 7 to 8 in bed, and the 2/3 we spend it either at work or within our social environment. So hence the contextual factors divided into 2 subgroups, the social and the occupational. Why occupational? The model was made in a perspective where we are treating adults. And what's the typical occupation of adults? Well, typically it's work, but occupation can have greater meaning as well. And domain number 3 that I haven't spoke about is comorbidities. We have to acknowledge that patients that are being seen by healthcare professionals don't only come with low back pain or other MSK problem. They are, or one particular MSK problems. Often they have other healthcare needs, other physical comorbidities, and other mental health comorbidities that needs to be taken into consideration. So that's why five domains. Each of those 5 domains are divided into 2. So hence the part A and part B, or domain. For each domain there's A and B, which is not very original. But it was just an attempt to try to illustrate the complexity of low back pain. A, elements within the A subgroup, or elements that can be probably more easy to target, easy to identify, target, and modify. Elements within the B subgroups are elements that are either really hard to modify, non-modifiable, or that would require more care by more than one healthcare professional. So that was the idea of dividing this into 2, just try to in order to try to illustrate the complexity of all of this.
Yeah, I think your model looks very complete, and I was wondering, for the non-modifiable factors, you suggest in your paper a more aggressive interdisciplinary care, or a more interdisciplinary approach. And I feel like in practice, this is where a lot of therapists, myself included, struggle, because maybe we don't have a great network with other therapists, and maybe not good enough communication. What's your opinion on that?
Well, you've pointed out a good buzzword, communication. So the idea is try to identify this and then communicate with the most appropriate healthcare professional. So let me give you a few examples. So if you see a patient that has general diffuse pain and allodynia, it's going to tell you, well, his pain it's probably, mechanistically speaking, it's going to be explained by nervous system dysfunction. Now, if you're a physical therapist, the treatment you're providing, are they going to be the most effective to address allodynia or those diffuse widespread pain? Well, maybe they're going to be effective, but maybe they're going to be more effective if you work with your physician. Maybe there's some pharmacological agents that are going to help the patient. The other example I can give is sleep. Many people with chronic pain or even acute pain will have disturbances in sleep. So is it disturbances that need to be, is it somebody that, wakes up at night, wakes up for a few minutes, turn on the other side and falls asleep? Well, then that's not a major disturbance. No. And we're probably well equipped for that. But for the people that get up at night, well, they wake up at night, they need to get up, they need to walk, they need to do something, and they can't fall back asleep, and they sleep for 3 hours. Well, again, maybe we need to work with somebody else. The other patient that may come to you with low back pain or pain elsewhere, and you might observe, you might screen that patient is in desperate need of help for his mental health. Maybe there's lots of anxiety, lots of evidence of depression, where we're not making that diagnosis, but there's evidence of depression. Then maybe it's going to be a good idea to call out a physician, a psychologist, an occupational therapist, somebody whose scope of practice is within that particular aspect. So that's why I think the word you mentioned was communication. Communication is a key. We need to communicate, and we need to take some weight off our shoulder and try to distribute it and work interdisciplinary with other healthcare professionals to address this. But to be able to do that, we need to assess it in the first place. So it's all about assessment. It's all about identifying or establishing the patient's profile beyond biomechanical aspect.
Yeah, clear. And where in the model would you put lifestyle factors, for example? Because we had a podcast, I think it was episode 58 or 59 about lifestyle. So where would you put that in a model?
So lifestyle factors or social determinants of health. They determine if your chances, your risk of developing health condition, and if you have that health condition, it's going to influence what's going to happen. So the pathway you're going to take. Now, those lifestyle factors are probably what's missing in the model. They're not explicit. They're not contextual factors. They're not factors from the person's environment itself. They're not truly bio or biomechanical. Yeah. They probably fit altogether, way beyond or they're overarching all of this. So I think nutrition might be something to consider. Alcohol consumption, etc. So all the lifestyle factors that we can identify with a patient or maybe targets. Now, when we did the model, we really looked at the literature to find tangible targets, things that people could probably have the opportunity to change on a short-term perspective and maybe not on a long-term perspective. And sometimes social determinants of health or lifestyle factors or habits or things that are going, just having somebody just smoking cessation is not something that's going to happen in a week or in a short time frame. So to answer your question, they would fit in there. They are not explicit in there, and it might be something that in a revised version or updated version that could be made more explicit.
Yeah, I hope you give me credits then if you expand it with lifestyle factors. No, just kidding. And looking at your model, how is it different from classification systems that we've seen in the past? Or in other words, why is it more than just a classification system?
Yeah. So in the model, it's quite explicit. We integrate classification system because classification system can really help us to identify specific subgroups of patients. But we also have to acknowledge that classification systems are mainly they have a strong biomechanical influence. They look at the nociceptive part, and we are trying to identify patient with a specific directional preference, for example, who's going to respond to manipulation or mobilization, etc., etc. So it's targeted mostly towards nociceptive or to some extent nervous system dysfunctions. And but we know that pain is not only biomechanical. So that's why we try to integrate these, use them, clinically use them, use their results, but also look at other factors because classification systems have their limits. For some patients, with only a biomechanical aspect, it's going to do the job. For more complex patients, it's going to do part of the job, probably not all of it. So how can we render the clinician to be more efficient and to identify what's going on, to identify the complete profile of his patient? Well, it's by including classification systems and also other factors. If we also include prognostic tools, for example, my personal philosophy to look at the presence of cognitive affective factors is probably to do a good screening. How can we screen for that instead of taking 56 questionnaires to the patient who's not going to understand exactly what's going to happen? It's going to be a big waste, probably a big waste of time. Well, the Start Back tool, which is a prognostic tool, which integrates many prognostic factors in one single tool. Now, what we have to take into consideration for the Start Back is that most of the factors included in that tool are psychological factors. So instead of looking at each cognitive or affective factors, let's use a prognostic tool. If the risk was going to be the risk assessment is going to be given by using that tool, puts the patient at medium or high risk, then the clinicians, they need to probably dig a bit deeper. The one tool is telling me that patient is at risk of developing persistent pain based on the presence of many psychological factors. So I should dig further to look which one. If the tool says, well, the patient is at low risk, well, then you're probably okay, meaning, well, those factors are likely or not likely to influence the outcome. So I can move or stay specific to nociceptive or nervous system dysfunction factors, depending. So I try to use them for screening purposes, and then if your screening is positive, well, then you dig a bit further.
Yeah, maybe that's a good transfer to a question that I have noted down here. Talking about the model, how would the patient history look like if I want to apply your model? Can you talk us through that?
So the notion that I like a lot is the notion of dashboard. In your car, you have a dashboard. So you know your speed, the engine, whether it's electric or not, you know what's happening. So we took that principle of a dashboard and try to illustrate that, make it happen with the model. So in the research projects that we've did, the patients were coming about 20 minutes earlier than their appointment time, and we asked them to fill out online a series of questionnaire which would identify the patient's pain level, its disability, type of pain, presence of psychological factors, etc. So with about 50-ish questions, which takes about 20 minutes to answer online, the clinician already has a dashboard of those results because they're analyzed automatically. So you're going to see the patient, you're going to know beforehand what's the pain intensity, how disabling it is, what's the type of pain. For example, we use the pain detect questionnaire, which gives you, is it more nociceptive or more neuropathic or mixed? We use the Start Back tool to help inform the clinician in regards to the risk of chronicity based on psychological factors, and we use another tool. So from then, it's going to be easier for the clinician to go from domain one, what's nociceptively speaking, what's happening. Domain two, is there any nervous system dysfunction involvement, hyperalgesia, allodynia, evidence of central sensitization? The clinician is already informed of those results. So the clinician knows it, well, no, there's no sensitization, or yes, there is. So if there is, I'm going to ask a bit more questions about that. Yeah. Same thing for comorbidities. How, are there any comorbidities are there physical or mental health? And then I'm going to dig a bit further and for each domain. So it provides a structure upon which the clinician can really integrate biological components, psychosocial components, occupational components, and try to see, all right, what's driving my patient's disability and pain? So in other words, what should I target my interventions on? Should it be only biomechanical because all the rest is clean? Or it's biomechanical and there's some things in there in regards to work. The patient doesn't like work. Lots of stress at work, lots of physical involvement at work. Oh, well, yes, I'm going to need to pay attention to this. So that's the structure that the model proposes.
Yeah, where can I get the dashboard for our own practice?
So the dashboard is not it's not commercially available. It's only available for research purposes. Yeah. However, if you want to have access to this on a paper perspective, paper or PDF, it's all outlined. We have a website. So there's two places you can find it. Online on PubMed. We have a study where we developed a tool. We looked at its content validity and then its reliability. So that is in open access. We also have a website, pddmmodel.wordpress.com, where you can also find this kind of precious information to help the clinician to structure his interview process.
Yeah, and that's the PDDM model rating scale you're talking about, I guess. Or is that another tool?
Exactly. No, it's the PDDM rating scale. Yes. Yeah. On the website, we have a mind map. So the mind map looks like a giant octopus with many colors. And that's it's not a tool to use clinically, but it's a tool that shows the clinical reasoning behind all of this. So that's available on the website pddmmodel.wordpress.com, and it speaks a lot about the clinical reasoning process behind the interview, the PROMs, the patient-reported outcome measures, the specific questions or physical examination procedures that we had in mind to try to identify which domains are problematic. Because the idea behind the model is not prescriptive in terms of intervention. The model is more to structure the evaluation. So I'd say it's more of a diagnostic framework.
Yeah.
That helps the clinician to identify targets for the treatment plan.
Okay, and to summarize it again and to make it more clear for myself, so the patients get sort of a screening 20 minutes earlier with those 50 questions. Then it's automatically processed, and the therapist has like an idea about where to dig deeper. And then after the 20 minutes, the patient comes in, and then there's further questions that you guys ask, or how do you continue from there?
All right. So we ask the clinician to we ask. Asking is a bit strong. I say we propose that the clinician either perform some physical examination or ask a few questions for each domain. So for the first domain, the nociceptive drivers of pain, the idea here is to use classification system. So can you classify your patient using a classification system? Whether it's a McKinsey classification system, the treatment-based classification system, can you subgroup your patient using a classification? If you can, well, the treatment proposed by the classification system are going to help you to take care of the nociceptive part. Now, in your patient, is it only nociceptive? Maybe not. So then you move on to domain number 2, which is nervous system dysfunction. To do that, well, you do what you're usually doing. So if there's symptoms or evidence of nervous system involvement, you're going to do a neuro exam. You're going to look at neural, slump, SLR, etc. So you're gonna have some targets. So it's basically doing what you're doing. The only thing that we are adding is to facilitate all of this is the results of the central sensitization index or central sensitization inventory, which is going to help you as a clinician to say, all right, is my patient's pain only nociceptive, or there's evidence of nervous system dysfunction, sensitization, to be more precise? Then, well, that can become a target. And then you can look, well, is there any evidence of allodynia, diffuse widespread pain, hyperalgesia, which might be widespread again. So then this becomes a therapeutic target. Domain number 3, in your assessment, well, you're going to look, all right, is my patient only coming in with low back pain, or there are other painful musculoskeletal problems? If you want to sensitize somebody's nervous system, let the pain be there and do nothing about it. So the idea here was to help clinicians recognize, all right, if there's other sources of pain, you need to address this. So if your patient has back pain, all right, but if there's neck pain, shoulder pain, knee pain, hip pain, etc., that is distinct from the original cause of pain, you need to address it as well to try to tone it down, because leaving a painful disorder just roaming, it's like leaving the fire on. It's going to sensitize the nervous system. And part B of that domain is looking at evidence of mental health disorders. So is it patient-reported, or are you going to be screening for that? There's tools actually that can help the clinicians to screen. Maybe clinicians are already using such tools. The Beck Depression Inventory is a tool to screen for evidence of depression. The PHQ-4, Patient Health Questionnaire 4 with 4 questions, it's a broad screening tool for anxiety and depression. It's not going to make a diagnosis, but it's going to tell you, you might dig a bit further into anxiety or depression, which are the 2 main mental health comorbidities that we see with a patient with a spinal problem. Afterwards, domain 4, cognitive affective. Well, what I recommend to use is a prognostic tool, namely either the Start Back or the Start MSK, who's going to tell you, well, what's the patient's risk of having persistent pain based on psychological factors. So if the risk is moderate to high, well, then you probably need to answer a few more questions. Is there any evidence of erroneous belief? So false, beliefs, cognitions such as pain catastrophizing, pain-related anxiety, fear of movement, fear of pain, etc. So you can dig a bit further. And that's going to tell you, well, I need to address these factors because these are barriers to recovery. If you have the right exercise for the patient, but the patient is really fearful of moving or has lots of anxiety in regards to pain, that exercise, it's probably not going to work until you reduce the fear of pain, of the fear of movement. If you reduce this, then your original exercise is much likely to work better with that patient. So it's a chicken or the egg, but you need to take this into consideration. And for some patients, those factors, those cognitive affective factors, might also be present in terms of maladaptive behaviors. For example, patients who really overlimit themselves, they restrict, they are so scared of having pain that their behavior is to remove themselves from that activity, from their work life, personal life, etc. If you see maladaptive behaviors, definitely what's driving this is often cognitive or affective factors. No. So again, chicken or the egg, if you see maladaptive behaviors, make sure you look at some specific factors, because that behavior is going to, again, probably be a barrier to recovery. And finally, the fifth domain, which relates to the patient's work or social environment, there's probably much more emphasis on work. But if the patient has stopped working, is on sick leave for whatever reason, etc., well, you need to look early if there are evidence of work-related factors that are going to inhibit or be barriers in time in terms of return to work. And those factors, sometimes we in physical therapy can address them, but sometimes we'll need help. We'll need to talk with the employer, to talk with person responsible. And here in Canada, I would say that occupational therapists are probably the best to do that. So it's a good opportunity, again, to collaborate with other healthcare professionals to provide the patient with the best specific care for for what's driving that pain.
Okay, great. Thank you for your answer. And you already mentioned that you use a lot of questionnaires in a model. What is the reasoning behind that?
All right. Well, what gets assessed gets improved. So we need to start somewhere. So the idea of the model is to assess and identify the potential targets. So that's why we rely on many PROMs, on many patient-reported outcome measures, or specific questionnaires that can help the clinician to really identify what is problematic or not. Just like there's many sensors in your cars to tell you your speed, the state of the engine, battery, etc., it's going to inform your decision. So the goal of those PROMs is to inform the decision that you are going to take. If you have no PROMs, I'm not sure you're on the, if you lose your dashboard, you can probably still drive your car, but you're putting yourself at higher risk of unwanted events.
Yeah, I agree. I think it's also a great way to objectify what you're assessing indeed.
Yeah, and we need to do that professionally. We need to, have an evidence-based practice. Well, we need evidence. So PROMs is a source of evidence to base our practice on specific targets, and also to identify if those problems are going or less problematic through time.
Yeah. Okay, I have an almost rhetorical question to you.
Yeah.
Non-specific low back pain, is it a helpful term?
Yeah, so what's my opinion on non-specific low back pain? Recently I did a presentation and I looked at that term. I dig to really understand it better. And did you know it came out in the literature for the first time it was in the literature was 1956. So many years ago, that term was used, and almost 70 years from it's still used. Now, I don't have a problem with non-specific no back pain. The only issue is that if I see your patient tomorrow, I replace you in the clinic, and you're telling me, oh, you're going to see this gentleman, he has non-specific low back pain. I'll have no idea where to begin or what to do with it. So the idea with non-specific low back pain, it's mostly to reassure the client that there's nothing major going on. It's you have an episode of low back pain. We are not really well equipped to identify what's the cause. Now, are we going to stay with low back pain, with non-specific low back pain? I think that if I would see your patient with non-specific low back pain, but you would provide me with prognostic-related elements, then I would probably be able to do a better job with your patient. So what's prognostic-related element? Treatment-based classification, McKinsey classification system are all about prognostic. So classification system. What are the main prognostic factors for patients with low back pain? There are mostly most of them are not biomechanical. They are mostly psychosocial factors. So I think that the profiling that we did with the model, so establishing the patient's profile based on mechanism and based on prognostic factors, I think that would be really helpful. And the model itself, I think, would serve to take something very generic like non-specific low back pain, and then you run the model, you see a patient with non-specific low back pain, so then you're certain it's a patient for you as a rehab professional. Now, what are the patient's needs? Well, to see what are the patient needs, you need the PDDM is probably a good structure to identify the patient's profile based on mechanism and prognostic. And then at the end, you'll have a patient with, yes, non-specific low back pain, which is a code in the ICD, but you'll be able to know much more precisely what to do with that patient, because you'll have identified the sources of or the drivers of pain and disability. So to clearly respond to your question, I think we are going to stay with that term for a while. We are going to be doing a much better job if we use the term, because it's a non-specific diagnosis, if we have prognostic-related information. And that's probably the way to be a bit more precise in regards to treatments or in regards to approach afterwards.
Yeah, I feel like the term is not only maybe difficult amongst clinicians, or like you said, you don't know what to expect if I tell you I have a patient with non-specific low back pain, but also for the patients, it's a bit unsatisfying because they want to know what's going on. Do you feel like if I tell them based on a model that their drivers of their condition or of their pain is this and that, is our comorbidities or our cognitive emotional factors, do you feel like they would be more satisfied with this answer?
Well, I think they're going to be more satisfied if you tell them here's my treatment plan. So you have non-specific low back pain, meaning that we cannot specifically identify the specific pathoanatomical cause of low back pain. But there's something in your back that's causing pain for sure, and because I believe you. Now, what are we going to do with that? All right, here's the results of my evaluation. I looked at all the major potential drivers of pain and disability, and I think that for your pain, we can do one specific exercise. So you say, let's say he has a directional preference. He's responding to extension, to pull-ups, extension, pain is centralizing. So he's going to understand, all right, that's going to take care of this. Now, later on, you mentioned to me, Mr., that you were quite fearful that pain would, stay through time and you had no tools to manage it. Here's what we are going to do with that. So I personally would be much more reassured by a clinician that's going to tell me a diagnosis. Yes, here's your diagnosis, all right, but here's what I'm going to do with it. So I think it's to render the treatment plan explicit. It's you probably have more chances of having the patient's buy-in in regards to that. And then, all right, so he knows where he's going. Kai, you know where you're going. Thank you. All right, so then the patient knows that exercise 1 and 2 is to take care of the nociceptive part. Exercise 4 is to take care of the nervous system part. And you're going to give your patient a handout about the XYZ, all right? And that's going to take care of the mostly cognitive or affective part. And you might also say, well, when the time comes, I think we are going to call your employer to make sure that you have proper break time when you go back to work, etc. So again, I think the patient would be quite reassured by the fact that you know where you're going, even though the diagnosis is not very specific.
Yeah, great stuff. And after the assessment process and the patient history taking, the goal of the model is to end up with a personalized rehabilitation management approach.
Yep.
And I'm sure many therapists have a good idea what they should do with a patient if the problems are in domain 1 and 2, so nociceptive or nervous system dysfunctions. But how would your approach look like if a patient has a lot going on in the other 3 dimensions?
Yeah.
And as a follow-up question, are we as physiotherapists qualified enough to cover those 3 dimensions?
All right, good question. So that is a really good question. So the model itself, it's not a prescriptive model. It's not going to tell you what to do. It's going to highlight where you need to target your care. Now, I do agree with you, for domain 1 and 2, usually physical therapists are really good at that. That's our natural bias. Yeah. Now, for the other domains, remember, we are not treating a back. We are treating a person. So we need a better understanding of that person's cognitions or emotion in regards to how he's feeling, handling, managing as low back pain. Or individually, are we all prepared to address these factors? Are we all well equipped to reduce pain catastrophization, for example? Well, I'm not convinced we are all. Now, is it within our scope of practice? Yes, it is within our scope of practice. We are not addressing things that are related to mental health, like everything within the DSM. We need help. We definitely need help for that. But to reduce a person's fear, to reduce a person's catastrophization or pain-related anxiety, there are ways that physical therapists can handle this. Now, do we have sufficient training when we enter the practice to do that? It depends. So again, I'm not convinced. Should we put more emphasis in those in our postgraduate education? The opportunities on that, probably. Here in Quebec and Canada, when I do the 1-day course about the model, half a day is dedicated to the assessment, and the other half is dedicated to, all right, now what do we do with that? And I put much more time or much more emphasis on the influence of psychosocial factors, because I know clinicians are probably already good with the use of classification system, or identifying specific exercises for that condition. So yes, we do need more training, but it's the chicken and the egg. So the egg, what is it that we need to do? We need to do a better assessment. We need to be able to clearly identify, all right, this is a target. Now, once you've done that, you need to address it. So that is part 2. And there are some professional development opportunities out there. And it might be something that if a clinician feels underprepared, underpowered for that might be a really good opportunity to pursue.
Yeah. Do you feel like it's a lot of talking to the patient for the domains if they come forward? Or
yes, it's talking, it's making sense. In that essence, the example that I give is that our job is to give. I'm going to do a cards analogy. If you play cards, whether it's poker or whatever game you like, our job is to. You love poker. Our job is to provide patient with cards. Usually, we are really good at providing a card that is physical exercise. All right. Now, that's the only card they have, or they have 1 or 2 cards. Now, the issue is that, I don't understand what's going on. I'm fearful of pain, and I think it's never going to get better. All right, well, maybe then we need a bit of talk therapy. Let's So, what is it that the patient understands of his condition? And that might be taking half an hour for that is really crucial. It's a concept called illness representation. So if you read about it, you're going to see lots of literature, and I think it's something underutilized by physical therapists. Just asking the patient, what do you think is driving your pain, is causing your pain? What do you think it's going to take to get you better? And that conversation can really help the clinician to understand, all right, my patient is illness representation is really on track or it's way off. If it's way off, you need to correct it. You need to provide patient education to bring it closer towards something which is more within the normal or acceptable range. So that's why patient education is important, but it needs to be targeted towards something that is relevant and important for that clinician. So just as a quick something that clinicians can remember, illness representation is underutilized, and it's a great opportunity to direct the education we do with our patients.
Yeah. Okay. I think we could talk about the model for ages. And you already presented it in 2017. Now we are 6 years further. What has changed until now?
So, well, the model that we presented in 2017 was a theoretical model. It was just a sales pitch. Here's something that can help you. Later, what we did in the recent year, well, we validated the model. We did a Delphi study to validate the content. We developed a rating scale, looked at its validity, its inter-rater reliability, and we did a few studies looking at it clinically. Is it acceptable? Is it changing outcomes? And things are positive. So we have, for low back pain, we have evidence to support that it's something interesting, something worth investing time in. Now, what's the next step? The next step on the short term is adapting that model for neck pain. Neck pain is not low back pain, and vice versa. There's going to be common elements, but there's going to be elements that are going to be a bit distinct from neck pain to low back pain. So we are working right now on a study where we are going to propose a PDDM for neck pain, validate it and test it clinically again to see if it's going to work. And in that new edition or new version, our intent also is to try to be a bit more prescriptive, not prescriptive formally, but at least when the profile is made, trying to just highlight, all right, dear clinician, here's what you could do for X, Y, Z, just to provide information or to help the clinician to target their care a bit more, and that care is aligned also with clinical practice guideline. So just to make sure that we're on the track for high value care.
Yeah. So you mean prescriptive regarding exercise or treatment options, or only
probably not necessarily exercise, but more treatment options. As you mentioned earlier in one of your previous questions. All right, let's say we identify that the patient has many cognitive affective factors, that are barriers to recovery. What do? All right, so then the idea would be to provide a few tips, clinical pearls for clinicians to, all right, oh yes, I'll be looking at this. This is how I'll be addressing it. Again, not prescriptive. I really think that clinicians have good judgment. They can use their experience. The idea is to use the evidence. All right, here's a bit of the evidence. It's quickly available. Now, what do I do with that evidence? I use my judgment. I use my experience, and I ask also the patient, the patient's perspective. So that would be the next iteration of that.
Yeah, I think this will be really helpful for clinicians for sure to come up with prescriptive examples.
And we are also trying to democratize the assessment tool, the online assessment tool that we develop. Right now, it's only used here for research purposes. But we are looking at different partners or different means to try to make it available for clinicians anywhere in the world.
Yeah, this would have been my follow-up question, because, I mean, the model, to me, it looks great. It makes a lot of sense. How can clinicians listening to this podcast apply it in practice? And maybe if it's too broad, could you give 3 tips for clinicians who would like to apply your model tomorrow or
So
the day after?
First, structure. Try to get within your head a structure, a clinical reasoning structure to go all over the 5 domains. Number 2, add PROMs, patient-reported outcome measures. We in the article we propose in the articles we publish, we propose a few PROMs that are specific to some domains. And number 3, try to target in your treatment plan the responses that you've had. So if there are 3 domains that are problematic, your treatment plans should be addressing those 3 problematic domains. Maybe not in the order in which it's going to be done remains to the clinician, but I would like to see, all right, here's my treatment plan for the problems in domain 1, domain 2, and domain 4, for example. So then, if I see your patient tomorrow, I'm going to have a good idea what to do. What are the drivers of pain, and where should I be going with all of this? And not strictly focus on pain itself, but also what's driving pain, disability, and coherent with the different drivers we identified in the model.
Okay. And for anyone listening out there, we will add all of the resources that we have about the PDDM model in the podcast description, as well as the transcript of this podcast episode. And Yannick, looking at the list of my questions, I'm coming towards an end. Is there anything that you would like to add?
No, I think the main message here that your listeners need to really understand is that the model proposes a structure to help them identify the multiple drivers of pain and disability in their patients. Can they apply it to other painful conditions? To some extent, we could say yes. Of course, other conditions will have very similar drivers of pain and disability, especially for nervous system dysfunctions or cognitive affective factors and even contextual factors. Maybe it's the nociceptive drivers where we were suggesting to really use classification system. Well, we know that classification system are there for the back, the neck, but not really, it's not the same thing for peripheral problem, for joint, knee, shoulder, etc. So there might be some discrepancies in there. However, I do feel confident that many physical therapists are really good at addressing biomechanical factors. So using the nociceptive and the nervous system dysfunctions domain in their day-to-day, what we need to get better at is really try to implement a true biopsychosocial approach, thus integrating cognitive affective factors and contextual factors. So I think this is where we need to take the biggest leap in our practice to really fully have a biopsychosocially sound approach.
Okay, great. And at last, where can people find you if they want to know more about the model or about your research?
Well, I'm on Twitter, YTL under YTLPT. I'm at the University of Sherbrooke, which is in Quebec, southern Quebec, just near the U.S. border, just south of Montreal. This is where I work. I just supervise my student, teach, and have fun playing outside. It's a great region of Quebec. If you guys ever want to visit, I would suggest that this time of year, fall, is probably the best season to visit. So September and October. And I'll be also at I'm presenting next July at the IFOMT conference in Basel, so really close to the German border. I'll be there early July, talking about prognostic-related information.
Okay. Yannick, thank you so much for your time and for your knowledge. It was a pleasure to have you. And also, thanks a lot for everyone listening out there. And to access the transcript and additional resources, make sure to sign up for free Physiotutors membership on physiotutors.com and benefit from more useful physio content. And as always, if you enjoyed this episode, hit the subscribe button or follow our podcast on Spotify or Apple Podcasts. And also consider leaving a review if you really enjoyed it. And with this being said, this was Kai for Physiotutors, and I'll see you in the next podcast episode. Bye.